What's up, my average med students? Welcome back to another episode. Today we're going to be covering GI from the TZANKI Step 2 deck. If you haven't already done so, please hit the subscribe button and press the bell icon to be notified of future posts. Happy studying.
1. What is the second most common cause of lower GI bleed in adults? Diverticulosis. 2. A patient presents complaining of dysphagia. He states that it feels like a knot or ball of food is stuck in his chest. You suspect achalasia. Barium swallow reveals a bird's beak sign. What is the most appropriate next test? Manometry and endoscopy rule out cancer. Achalasia key points. Barium swallow is the best initial test. Manometry follows here and offers more info. Endoscopy must be done to rule out cancer. Treatment is preferred. Heller myotomy. Balloon dilatation can cause perforation. Botox is less effective. 3. Ulcerative colitis involves an increased risk of cancer as there is long-standing inflammation. As such, colonoscopy screening is important. When should it begin? Start 8 years after diagnosis and continue with annual screening. 4. GI antiemetics. Vomitorium, motion sickness, vestibular nausea is treated with first-generation antihistamines diphenhydramine, meclizine, and scopolamine. H1 receptor blockers and M1 receptor blockers. 5. A painless, palpable gallbladder in pancreatic adenocarcinoma is also known as the Courvoisier sign. May also be seen in cholangiocarcinoma. 6. What is the best non-invasive test to confirm diagnosis of H. pylori infection? Urea breath test. 7. What antimycobacterial drug can cause drug-induced lupus? Isoniazid. What antibody is characteristically elevated in drug-induced lupus? Antihistone antibodies. 8. What is the likely diagnosis for a solid, hyperechoic liver mass in a young woman on oral contraceptives? Hepatic adenoma, typically seen as a well-demarcated, hyperechoic lesion. 9. Are hepatic adenomas typically benign or malignant? Benign. Possible long-term complications include progressive growth, rupture, and malignant transformation. 10. Is needle biopsy recommended for a patient with a hepatic adenoma? No, due to risk of bleeding, surgical excision is preferred. 11. Which form of dysphagia, oropharyngeal or esophageal, is characterized by coughing, choking, or nasal regurgitation on swallowing? Oropharyngeal. 12. What is the preferred initial study to evaluate patients with suspected oropharyngeal dysphagia? Videofluoroscopic. Modified barium swallow evaluates swallowing mechanics, degree of dysfunction, and severity of aspiration characterized by difficulty initiating a swallow. Underlying etiologies include stroke, NMS disorders, Zenker diverticulum. 13. What IBD complication presents with colonic dilation on X-ray and fever, tachycardia, leukocytosis, and or anemia? Toxic megacolon. May also have severe bloody diarrhea. Highest risk of developing toxic megacolon is early on in the disease. 14. Toxic megacolon is a medical emergency that requires nasogastric decompression, antibiotics, IV fluids plus steroids if IBD is associated. If the colitis does not resolve, emergency surgery may be required. 15. What is the likely diagnosis in a patient with extensive alcohol use who presents with severe retrosternal pain and subcutaneous emphysema after vomiting? Esophageal perforation. Boerhaave syndrome. Other symptoms include dyspnea, odonophagia, and signs of sepsis. It is a surgical emergency. 16. What is the first test or imaging study that should be ordered to diagnose pancreatitis in a patient with acute epigastric abdominal pain that radiates to the back? Serum amylase and lipase. If amylase or lipase is greater than 3 times normal, may not need confirmatory imaging for diagnosis. Order amylase and lipase to confirm diagnosis, then do imaging to identify the etiology, for example, gallstones. 17. What imaging modality is most useful for diagnosing acute pancreatitis if laboratory testing is unclear? Contrast-enhanced CT scan. Nearly 30% of patients have an ileus with bowel gas that prevents ultrasound from fully visualizing the pancreas. 18. What diagnosis should be suspected in patients with multiple duodenal ulcers refractory to treatment or ulcers distal to the duodenum? Zollinger-Ellison syndrome. 19. What is the underlying cause of fat malabsorption in patients with Zollinger-Ellison syndrome? Pancreatic enzyme inactivation due to excess gastric acid in the small intestine. 20. Which trace mineral deficiency manifests as thyroid dysfunction and cardiomyopathy? Selenium deficiency. Risk factors for deficiency include malabsorption, bowel resection, poor nutritional intake, and parenteral nutrition. 21. Which trace mineral deficiency manifests as brittle hair, neurologic dysfunction, and sideroblastic anemia? Copper deficiency. Risk factors for deficiency include malabsorption, bowel resection, poor nutritional intake, and parenteral nutrition. 22. What is the colonoscopy screening recommendation for patients with Lynch syndrome (HNPCC)? Begin at age 20 to 25, repeat every 1 to 2 years. 23. The primary inciting event of acute cholecystitis is typically a gallstone obstructing the cystic duct, with subsequent inflammation and infection. 24. What surgical procedure is preferred for biliary drainage for patients with acute cholangitis? ERCP with sphincterotomy. Other options include percutaneous transhepatic cholangiography and open surgical decompression. 25. What procedure should be done prior to endoscopic treatment in patients with an upper GI bleed who have a depressed level of consciousness and continued hematemesis? Endotracheal intubation. These patients are at high risk for aspiration and must have their airway protected before upper endoscopy. 26. What hormone analog is useful for the treatment of variceal hemorrhage? Octreotide somatostatin analog causes splanchnic vasoconstriction and reduces portal blood flow by inhibiting release of glucagon. Prophylactic antibiotics like IV ceftriaxone should be administered as well. 27. What is the likely diagnosis in an elderly patient with conjugated hyperbilirubinemia, elevated alkaline phosphatase, and painless jaundice? Malignant biliary obstruction. 28. What is the likely diagnosis in a patient with melena and epigastric abdominal pain that is relieved with eating? Peptic ulcer disease, duodenal ulcer. 29. What is the likely diagnosis in a young patient with liver disease and neuropsychiatric symptoms? Wilson disease. 30. Low serum ceruloplasmin with elevated urinary copper excretion suggests a diagnosis of Wilson disease. Other diagnostic features include Kayser-Fleischer rings and increased copper content on liver biopsy. 31. Which form of inflammatory bowel disease is characterized by mucosal inflammation and crypt abscesses on biopsy? Ulcerative colitis. 32. Which form of inflammatory bowel disease is characterized by transmural inflammation and non-caseating granulomas on biopsy? Crohn's disease. 33. What is the recommended management for variceal hemorrhage if there is continued bleeding after endoscopic therapy? Balloon tamponade until TIPS or shunt surgery. 34. Porcelain gallbladder is associated with an increased risk for gallbladder adenocarcinoma and usually requires cholecystectomy, often found in patients with chronic cholecystitis. 35. Which form of inflammatory bowel disease is characterized by continuous colonic involvement? Ulcerative colitis. 36. Dilation of the pancreatic duct and common bile duct. Double duct sign may occur with tumors of the head of the pancreas. You might see both intra and extrahepatic biliary tract dilation. 37. What imaging modality is used to aid in the diagnosis of toxic megacolon? Abdominal X-ray diagnosis made by radiologic evidence of colonic distension with manifestations of severe systemic toxicity. 38. What is the likely diagnosis in a patient with episodes of dysphagia, regurgitation, and chest pain with radiation to the back that is precipitated by emotional stress? Diffuse esophageal spasm symptoms may be relieved by nitrates or calcium channel blockers, which relax myocytes in the esophagus. 39. What test is used to establish the diagnosis of spontaneous bacterial peritonitis? Paracentesis diagnostic criteria, positive ascites fluid culture and PMN greater than 250 mm3 should be done before antibiotic therapy, which often results in negative ascites cultures. 42. What as-to-alt ratio is indicative of heavy alcohol use? Greater than 2:1 as-to-alt. 43. What is the likely diagnosis in a patient with fever, jaundice, tender hepatomegaly, and as-to-alt ratio greater than 2? Alcoholic hepatitis. 44. What is the underlying cause of edema in patients with cirrhosis? Hypoalbuminemia, synthetic dysfunction. 45. What imaging modality is preferred for diagnosis of chronic mesenteric ischemia? CT angiography, same for acute mesenteric ischemia. 46. What pharmaceutical therapy is recommended for prophylactic treatment of non-bleeding esophageal varices? Non-selective beta blockers like propranolol, nadolol, and endoscopic variceal ligation can be used as an alternate primary prevention therapy in patients with contraindications to beta blockers. 47. Chest X-ray findings consistent with esophageal perforation include left-sided pleural effusion, subcutaneous emphysema, and widened mediastinum. Pleural effusion is typically left-sided because the esophagus is positioned on the left anatomically. 48. Patients who complain of persistent abdominal pain after cholecystectomy should be evaluated for post-cholecystectomy syndrome. Evaluated via abdominal imaging like ultrasound followed by direct visualization, e.g., ERCP, MRCP to find the causative factor. 49. The absolute values of AST and ALT in alcoholic hepatitis are almost always lesser than 500 IUL. Usually lesser than 300 IUL versus other causes of hepatitis, which cause much greater elevations. 50. What is the likely diagnosis for a patient with an acute, massive increase in AST-to-ALT in the setting of hypotension? Ischemic hepatic injury, shock liver, often accompanied by modest elevations in total bilirubin and alkaline phosphatase. 51. What is the most common source of liver metastasis? Colorectal cancer. In addition to tumors of the GI tract, lung and breast tumors also commonly metastasize to the liver. 52. Does achalasia result in dysphagia to solids, liquids, or both? both solids and liquids. 53. What test is most accurate for diagnosis of achalasia? Esophageal manometry findings include high less resting pressure and incomplete less relaxation. Barium esophagram is sometimes used as an initial test. 54. What is the likely diagnosis in a patient with chronic, episodic epigastric pain that suddenly worsens X-ray findings? Below, imaging previously showed gallstones in the gallbladder. Perforated peptic ulcer. 55. What tuberculosis drug is most commonly associated with liver injury? Isoniazid is an idiosyncratic injury with histological features similar to those seen with viral hepatitis such as hepatic cell necrosis, mononuclear infiltration. 56. What is the likely diagnosis in a patient status post-Roux-en-Y gastric bypass surgery who presents with abdominal bloating, diarrhea, and macrocytic anemia? Small intestinal bacterial overgrowth. Macrocytic anemia due to vitamin B12 and folate deficiencies. Bacteria deconjugate bile acids and increase vitamin B12 turnover. 57. Small intestinal bacterial overgrowth may be diagnosed via carbohydrate breath testing or jejunal aspirate or culture. 58. Primary biliary cholangitis is an autoimmune disease characterized by destruction of intrahepatic bile ducts. 59. What antibody is characteristically elevated in primary biliary cholangitis? Anti-mitochondrial antibody. 60. What pharmaceutical treatment is helpful for delaying the progression of primary biliary cholangitis? Ursodeoxycholic acid should be initiated as soon as the diagnosis of PBC is made. Patients with advanced disease may require liver transplantation. 61. What is the next step after an endoscopic biopsy is positive for gastric adenocarcinoma? CT scan of abdomen and pelvis imaging helps with disease staging, which determines prognosis and treatment options. 62. What is the first-line treatment for diffuse esophageal spasm? Calcium channel blockers like diltiazem. Alternatives include nitrates or TCAS. 63. Patients with small intestinal mucosal disease, celiac, will have decreased levels of urinary D-xylose. D-xylose is a monosaccharide that only depends on viable mucosa, not enzymatic breakdown for absorption in the proximal small bowel. 64. Patients with enzyme deficiencies like pancreatic insufficiency, lactose intolerance will have normal levels of urinary D-xylose. D-xylose is a monosaccharide that only depends on viable mucosa, not enzymatic breakdown for absorption in the proximal small bowel. 65. What is the likely diagnosis in a patient with abdominal pain and hematemesis following recent use of alcohol, aspirin, and cocaine? Acute erosive gastropathy characterized by development of severe hemorrhagic lesions after exposure to various injurious agents. Hallmark is development of hemorrhagic and erosive lesions shortly after exposure of gastric mucosa to various substances or reduction in mucosal blood flow. Things like NSAIDs and alcohol direct injury or burns, sepsis, trauma, hypoxia of mucosa cause loss of the protective barrier, and permits acid and other substances to penetrate into the laminate propria. 66. What dietary habits decrease the risk of diverticulosis complications such as hemorrhage, diverticulitis? High fiber intake. Physical activity is also inversely correlated with the risk of complications. 67. What imaging test is used to evaluate bright red blood per rectum in a patient greater than 50 years old or lesser than 50 years old with risk factors for CRC? Colonoscopy. 68. A positive urine urobilinogen assay is typically indicative of a buildup of unconjugated bilirubin. Excess unconjugated bilirubin water insoluble undergoes regular conjugation, forming urobilinogen, which is excreted in urine and feces. 69. What imaging modality is recommended to evaluate patients with suspected gallstone pancreatitis? Ultrasound RUQCT is not as sensitive as US for detecting gallstones. 70. What is the most significant environmental risk factor for pancreatic cancer? Smoking and alcohol can cause chronic pancreatitis, which is associated with increased risk of pancreatic cancer, but it is not as significant as association between smoking and pancreatic cancer. 71. What is the likely diagnosis in an elderly man with dysphagia, regurgitation, halitosis, and aspiration? Zenker's diverticulum treatment is generally surgical. 72. What is the test of choice for confirming the diagnosis of Zenker's diverticulum? Barium esophagram. 73. What is the underlying etiology behind most malt lymphomas of the stomach? H. pylori infection. Those with early-stage malt lymphoma and confirmed H. pylori infection typically achieve complete remission with antibiotic treatment. 74. What is the likely diagnosis in a patient with diverticulosis, pneumaturia, and frequent UTI? Colovesical fistula. 75. What imaging study is used to confirm the diagnosis of a colovesical fistula? Abdominal CT with oral or rectal contrast, not IV. 76. What antibiotic should be started for patients with severe C. difficile colitis, WBC 15 to 20,000, and what is the route of delivery? Oral vancomycin, not IVC. Diff is one of the rare indications for oral vancomycin in C. difficile infections. However, intravenous administration is ineffective, as vancomycin is hardly excreted into the colon, the main site of infection. 77. What is the initial management for a patient with suspected GERD who has a bitter taste, substernal chest pain, dysphagia, and weight loss? Endoscopy. 78. Which type of esophageal cancer is associated with GERD, Barrett esophagus, and obesity? Adenocarcinoma. 79. What test or imaging study is used to diagnose esophageal cancer? Endoscopy with biopsy may use CT or PET, CT for staging. 80. What is the likely diagnosis in a middle-aged man with fatigue, pruritus, ulcerative colitis, and elevated alkaline phosphatase? Primary sclerosing cholangitis. 81. What antibody is associated with primary sclerosing cholangitis? PANCA. 82. What biliary disease is characterized by a beads on a string appearance on imaging? Primary sclerosing cholangitis. 83. What is the likely diagnosis in an elderly patient with chronic constipation, LLQ, abdominal pain, fever, and leukocytosis? Acute diverticulitis. 84. What test or imaging study is used for diagnosis of acute diverticulitis? Abdominal CT scan, oral and IV contrast. 85. TZANKI or diverticulum occurs due to posterior herniation between the fibers of the cricopharyngeal muscle, immediately above the upper esophageal sphincter. 86. What is the diagnostic step required in a patient with suspected C. difficile colitis? Stool study for toxin PCR. 87. Patients with severe C. difficile require treatment with oral vancomycin, one of the few indications for oral administration. 88. What are the most common extraintestinal manifestations of ulcerative colitis? Primary sclerosing cholangitis, arthritis uveitis, erythema nodosum, pyoderma gangrenosum, of Thus ulcers. 89. First-line medications for Wilson's disease, copper chelators, penicillamine, tritine, oral zinc may be used for maintenance therapy. 90. The stool pH and lactose intolerance is acidic. 91. The Hammond sign is a crepitus heard and Boerhaave syndrome with each heartbeat indicating air in the mediastinum. 92. What is the diagnosis of Boerhaave syndrome in a stable and unstable patient? Stable gastrograph and swallow water-soluble. Unstable CT scan. Do not start out with EGD. Camera may go through perforation. Do not do barium. Swallow non-water-soluble. Barium enters mediastinum. Mediastinitis. 93. What are the GI manifestations of cholesterol crystal embolism? Pancreatitis and mesenteric ischemia. Acute mesenteric ischemia equals embolic blockage of SMA. Chronic equals atherosclerosis. 94. What is the test of choice for spontaneous bacterial peritonitis? Paracentesis. Diagnostic criteria: PMNs greater than 250 mm3, positive culture E. coli, Klebsiella, SAAG greater than 1.1. Do antibiotics after paracentesis, since antibiotic therapy can cause negative ascites cultures. 95. What group of patients are spontaneous bacterial peritonitis seen in? Cirrhosis in ascites accompanied by fever or altered mental status. 96. Why can Zollinger-Ellison syndrome present with diarrhea and steatorrhea? Increased gastric acid secretion decreases the pH of intestinal contents. Inactivating digestive enzymes interferes with emulsification of fat by bile acids and damages epithelial cells and villi, leading to malabsorption. 97. Pass-positive macrophages in the lamina propria is seen with Whipple's disease. Contain acid-fast bacilli. Extraintestinal manifestations: can, cardiac, arthralgias, neurologic. May also see lymphadenopathy, skin changes. 98. What type of diet will predispose to niacin deficiency and why? Corn-based diets. Corn is deficient in tryptophan and niacin. What other causes are there? 3. Hartnup disease. Loss of tryptophan. Reabsorption. Carcinoid syndrome. Tryptophan used to synthesize serotonin. Isoniazid B6 deficiency. 99. What pharmacological agent can predispose to niacin deficiency? Pellagra. Isoniazid pathogenesis, B6 deficiency, which is required to produce tryptophan. Give them niacin. 100. Patients with angiodysplasia are more likely to bleed if they have other coexisting pathologies. End-stage renal disease, VWD, aortic stenosis. Pathogenesis low yield but informative. Aortic stenosis, a V replacement leading to shear stress. Cleaves VWF. Multimers causing platelet activation causing bleeding. VWF normally suppresses angiogenesis leading to VWF equals angiogenesis equals angiodysplasia. 101. Bleeding from angiodysplasia with aortic stenosis has been called Hayes syndrome. Aortic stenosis leads to shear stress leading to acquired VWF deficiency, causes increased bleeding. VWF deficiency also increases angiogenesis. VWF normally suppresses angiogenesis. 102. Patients with carcinoid syndrome are at increased risk of niacin deficiency producing pellagra. Increased tryptophan means more for serotonin but less for niacin. 103. The difference in the albumin gradient between the serum and ascites is called the SAAG serum ascites albumin gradient. What is the cutoff? Greater than 1.1 is highly suggestive of portal hypertension as the cause of ascites. 104. Rapid diagnosis. Most likely diagnosis in a middle-aged woman with pruritus, xanthomas, and a plus antimitochondrial antibody. Primary biliary cholangitis B equals bitch. Serum lipids may be markedly elevated. Primary sclerosing cholangitis equals males. 105. What are the 5 causes of pill esophagitis? Tetracyclines, NSAIDs, bisphosphonates alendronate, potassium chloride. Iron endoscopy will show discrete ulcers with normal appearing surrounding mucosa. 106. Rapid diagnosis. Major differentials for ALT greater than AST in the 1000 seconds. Viral hepatitis, toxin acetaminophen, ischemic hepatitis. 107. Rapid diagnosis. Anti-mitochondrial antibodies for primary biliary cholangitis. 108. What are the differentials for air in the gallbladder? Emphysematous cholecystitis GB infected with gas-forming organisms like Clostridium pneumabilia air secondary to gallstone ileus pneumabilia emphysematous cholecystitis, necrotizing soft tissue infection. 109. Rapid diagnosis. What is the likely diagnosis in a 42-year-old male with abdominal pain, bloody stools, and fatigue? Labs show elevated alkaline phosphatase. IBD. Ulcerative colitis with primary sclerosing cholangitis. Look for elevated ESR and PI-NCA testing. ERCP of PSC shows pearls on a string, inflammation and fibrosis of intra-extrahepatic bile ducts. 110. What happens to BUNCR in an upper GI bleed? Increased BUNCR ratio. Blood in upper GI can raise the bun. Patients with lower GI bleed do not have. Possible explanations include increased urea production from breakdown of hemoglobin. 111. Which paraneoplastic is commonly associated with pancreatic cancer? Migratory thrombophlebitis Trousseau syndrome. 112. What is the pathogenesis of Zollinger-Ellison syndrome? Gastrinoma. High gastrin secretion. Acid production. Multiple refractory ulcers associated with men. 1. Acid inactivates pancreatic enzymes, hence steatorrhea and malabsorption. 113. Which infantile abdominal wall defect will contain non-membrane over the abdominal contents? Gastroschisis. 114. Hepatic adenomas are commonly found in women and are associated with history of contraceptive and steroid use. 116. The diagnosis primary biliary cholangitis requires 2 out of 3 of the following. 1. Positive anti-mitochondrial antibodies. 2. Elevated ALK phosphatase. 3. Liver biopsy revealing destruction of intrahepatic bile ducts. 117. Patients with carcinoid syndrome may develop symptoms of pellagra secondary to niacin deficiency due to shunting of tryptophan to serotonin causing dermatitis, dementia, diarrhea. 118. Rapid diagnosis. Bloody diarrhea followed by colonic distension, peritonitis, systemic toxicity, fever, leukocytosis, hypotension. Diagnosis. Toxic megacolon shows colonic distension on X-ray. 119. What is the most likely diagnosis in a female on OCPs with a palpable abdominal mass or spontaneous rupture? Hepatic adenoma treatment. Discontinue OCPs, resect if large or pregnancy desired estrogen makes them grow. 120. A 4.2 centimeters hepatic mass found in a female. CT shows mass with a central scar. What is the next step? Focal nodular hyperplasia usually asymptomatic requiring no treatment. Hyperplastic response causing scar and center of nodules. Surgery is an option if the patient complains of RUQ pain. 121. Diffuse esophageal spasm pathology. Spontaneous contractions with normal less pressure patient. Non-cardiac chest pain that mimics angina may radiate. Diagnosis. Roax troponin. ECG barium. Corkscrew esophagus 50% manometry diagnostic. Normal less pressure. Multiple contractions that occur after swallow treatment. Medical. Nitrates. CCB. 122. What is the triad of Plummer-Vinson? Upper esophageal web dysphagia, Koilonychia spoon-shaped fingernails, iron deficiency anemia treatment. Iron, EGD with biopsy precancerous. Do not do prophylaxis esophagectomy. 123. Zenker diverticulum path. Diverticulum at Killian's triangle. Failure of cricopharyngeal MM to relax presentation. Greater than 50 years of age male. Halitosis, dysphagia, regurgitation of undigested food. Diagnosis. Barium best confirmatory test fills diverticulum treatment. Cricopharyngeal myotomy. 124. A patient with active lower GI bleed remains unstable after resuscitation. What is the next best step? Arteriography. 125. Acute mesenteric ischemia pathogenesis. Gut attack. Arterial embolism of fib. Recent MI number 1. Arterial thrombosis. Vasculopath. Atherosclerosis. Presentation. Vasculopath of fib patient. Lower GI bleed. Pain out of proportion to exam. Diagnosis. Angiogram. Confirmatory labs equals LDH. Lactate. Leukocytosis. Treatment. Unstable or signs of peritonitis. No imaging. Emergency lap. Stable equals endovascular approach. Angioplasty. Stent. 126. Ischemic colitis pathogenesis. Hypotension, hypovolemia, perfusion of watershed areas, splenic flexure. Presentation. Hypotensive shock. Recent aortic surgery. AAA repair. Diagnosis. Colonoscopy. LDH. Lactate if severe treatment. Supportive. Surgery if severe peritonitis. Sepsis. 127. Chronic hepatitis B can be treated with nucleotide analogs such as tenofovir and entecavir, as well as pegylated interferon alpha. Antiviral treatment nucleotide analogs tenofovir 1 pegylated interferon alpha, contraindicated in pregnancy, liver transplant, and cases of end-stage renal disease. 128. What is the etiology of chronic mesenteric ischemia? Atherosclerosis, triad of postprandial epigastric pain, food aversion, and weight loss. Remember, atherosclerosis is a chronic process. 129. Acute liver failure diagnostic requirements include severe acute liver injury with ALT and AST often greater than 1,000, signs of hepatic encephalopathy, confusion, tremor, and synthetic liver dysfunction INR greater than 1.5. 131. Rapid diagnosis, most likely diagnosis in older patient with solitary liver mass, iron deficiency anemia, and positive fecal occult blood test. Metastatic liver disease secondary to hepatocellular carcinoma. 132. What is the most likely diagnosis in an older male with decreased libido and erectile dysfunction and weight loss? Physical shows bilateral gynecomastia and small testes, and labs show normal TSH with decreased total T3 and T4. History is positive for alcohol use. Chronic liver disease, liver cirrhosis, and testicular atrophy are due to hypogonadism. Cirrhosis can cause hypogonadism and excess estrogen, producing telangiectasias, palmaroerythema, testicular atrophy, and gynecomastia. Liver also produces TBG, which binds thyroid hormones. Lowers total T3 and T4, but free T3 and T4 are unchanged, and thus TSH is normal. 133. Pseudoachalasia is a narrowing of the distal esophagus secondary to causes other than denervation achalasia, such as esophageal cancer. In this case, an endoscopy must be performed to exclude malignancy. Looks for clues such as weight loss, acute onset, and age greater than 60. Endoscopic evaluation is required to differentiate between achalasia and pseudoachalasia. 134. A young patient presents with abdominal pain and cramps accompanied with bloody diarrhea and nausea. His symptoms are suspicious for IBD. Exam reveals abdominal distension and tenderness with no rebound tenderness. Vitals show a fever, hypotension, and tachycardia. Aside from fluids, what is the next best step? X-ray bloody diarrhea, abdominal distension, and signs of sepsis indicate toxic megacolon secondary to IBD. Key to diagnosis is radiologic evidence. Do not perform enema or colonoscopy due to risk of toxic perforation. 135. What is the best diagnostic test for patients with primary sclerosing cholangitis? MRCP, magnetic resonance cholangioppancreatography, or ERCP. MRCP is imaging technique using MRI to visualize the biliary and pancreatic ducts. Biopsy is not necessary for diagnosis, but will show an onion skin pattern. Biopsy will not be the answer. 136. What is the underlying etiology of a patient with black stools and progressive confusion? He has a past medical history of hepatitis C and a physical exam shows asterixis. Hepatic encephalopathy secondary to gastrointestinal bleed. Hepatic encephalopathy is a disorder of the nervous system seen in patients with decompensated liver disease. Look for precipitating factors. 137. What is the underlying pathophysiological cause of ascites in a patient with a SAAG score greater than 1.1? Increased hydrostatic pressure. Etiology can be determined using SAAG. Greater than 1.1 indicates portal hypertension, increased hydrostatic pressure, and lesser than 1.1 indicates hypoalbuminemia or malignancy, decreased oncotic pressure. 138. What is the underlying pathophysiological cause of ascites in a patient with a SAAG score lesser than 1.1 GDL? Decreased osmotic gradient secondary to hypoalbuminemia, nephrotic syndrome, malnutrition, and malignancy, commonly ovarian or peritoneal mesothelioma. Liver cancer as well due to loss of synthetic function. Etiology can be determined using SAAG. Greater than 1.1 indicates portal hypertension, increased hydrostatic pressure, and lesser than 1.1 indicates hypoalbuminemia, malignancy, decreased oncotic pressure. 139. Hypokalemia and metabolic alkalosis can precipitate hepatic encephalopathy, leading to lethargy, confusion, and asterixis. 1. Be careful when giving diuretics, which can precipitate low intravascular volume and hypokalemia. 2. As a result, patients with HE and hypokalemia require potassium repletion in addition to intravascular volume repletion. 140. Hypokalemia and metabolic alkalosis can precipitate hepatic encephalopathy, leading to lethargy, confusion, and asterixis. 1. Be careful when giving diuretics, which can precipitate low intravascular volume and hypokalemia. 2. As a result, patients with HE and hypokalemia require potassium repletion in addition to intravascular volume repletion.